نجا يا مولاه وتخلى عن وصفك وتحلى بصفات الله نفتتح بلا حول ولا قوة إلا بالله.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back in SMIC's psychiatric series with Dr. Abdelwahed Abu Jazia, where we explore and Dr. Abdelwahed explores and explains to us the different disorders and ways to prevent them and treat them. Our topics for today will be about ADD وهي قصور الانتباه وفرط الحركة. أتاكسيا اللي هو فقد انتظام الحركة. أنروكسيا نيرفوسا فقد الشهية العصبي. Premenstrual syndrome التوتر والدورة الشهرية. Postpartum depression اكتئاب ما بعد الولادة. Jazakallah khairan, Dr. Abdelwahed, for coming today and joining us and giving us all of these valuable information. And thank you for responding to the cases that needed your help and providing solutions and advices. Thank you so much.
You are welcome, Ibrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Screen shared or no?
Yeah, it's screen shared. I can see it.
Okay, good. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me much pleasure to be with you today, and thank you for SMIC and all people working in SMIC for that chance to give you some psychiatric information about some of the main psychiatric troubles or disorders. Today we're going to start with adult attention deficit disorder, adult attention deficit hyperactivity disorder, ADHD.
I'm sorry, just 1 second. I think your voice is a little low.
Little, okay. So I will increase the voice. Okay. Just like that.
Like if you can make it louder, maybe.
Is it clear like it or no? Okay.
Yeah.
Is it clear like that?
Yeah.
Now it's better?
Yeah, thank you so much. Yeah, it's better.
Okay, good. Okay, alhamdulillah. So today we're going to start about adult or attention deficit hyperactivity disorders. Okay. What is ADHD? ADHD is a consistent pattern of inattention and hyperactivity, impulsivity, which interfere with functioning and or development. So the attention deficit hyperactivity disorder has 3 components: inattention, hyperactivity, and impulsivity. Sometimes we classify it into attentive type, hyperactive type, or mixed type. So inattention it means when you have a task, certain task, you do not go through the focus needed for this task. So you keep moving around the task, wandering over the task, or lacking persistence. Okay, you sit in your seat, for example, for 5-10 minutes, then you try to feel bored and you try to, can I get a break for a while? Can I wake up? Can I go, for example, to get some water? It is inattentive. Or when you are working on the task, you lose the attention. So the task is 5 or 6 steps. You do 1, 2, 3. Oh, how many steps I went through? I forgot. I didn't persist through. Difficulty sustaining the focus. Okay. Hey, in the class, look at me. Follow my lessons. Don't get your eyes away from me, for example. I do like that 5, 6, 7 minutes. Then I wander around. I take my eyes away from the attained focus or the prescribed focus for me. Disorganized. Due to this inattention, the person is disorganized because he can't understand clearly what is needed for the task. So For example, if we are giving an example for a task to go outside to get a cup of water, fill it, then go to water the plants. He might get the cup, lift it, put it in front of you, forgot to bring the water, forgot to fill it with water, or he might bring the cup, fill it with water, and forgot to go outside to put for the plant. So he is disorganized. In the hyperactivity domain, excessive motor activity. I am in the class, for example, I keep shaking hands, moving, pulling my legs, shaking my legs, okay? I can't stand still for more than 5 or 6 or 10 minutes. I always move. I touch my friend, I touch my colleague in the class, I go for my bag, for example, I go for my sandwich, I go for my bottle of water. So excessive motor activity. Fidgeting. Fidgeting, it means when we move in a line, for example, we move smoothly according to the line, according to the flow. No, move, rush in front, rush in the back, okay, touch all people around. Exactly. Sometimes you see people in driving a car in a line, going through a tunnel or something, you find someone moving smoothly. This one, he breaks the pedal, pushes the pedal, suddenly his car moves fast, then stops suddenly. He is fidgeting in movement, tapping. Okay, keep moving. Any kind of distracting movement he might do for hyperactive type. Talkativeness. Out of the blue, he speak, he talk without permission from the teacher, for example, in the class or from the leader in the group. Okay, extreme restlessness. He doesn't feel comfortable while he is sitting in one place. So he keep moving around, okay, and giving the others the sense of uncomfortability. They feel bored and uncomfortable also. The impulsivity domain. The impulsivity, hasty action that occur in the moment, minimal forethoughts. We are standing, out of the blue, he jump in front of moving a vehicle, for example, or moving somebody to obstruct him or to make obstacle in front of him. Or we are playing, out of the blue, he pushed the ball or he hit the ball out of the blue without rearranging the team, for example. Okay, or even without looking around to see who he has to bat the ball through. Okay, high potential of harm for the individual. This impulsivity, for example, he is discussing one of his colleagues, for example, in something. Out of the blue, he slaps his colleague. He can't control the impulsivity action. Social intrusiveness. We are 3 or 5 people speaking, and he, out of the blue, he comes suddenly intrude into the social gathering and start to speak, for example. Nobody invited him. Nobody asked him to indulge in our group of 3 or 5 people. Major life decisions. He has a car. Tomorrow, he sold the car. I decided to sell it. I didn't like it. Without thinking, without second thought, without asking his colleagues or his peers or even his wife, for example, what if we sold our car right now? Despite tomorrow, we were arranging in the house to travel in a long distance trip, depending on our car, but he came out of business, sold his car already. So he might ruin all the trip for his impulsive decision. How common ADHD? Global population survey suggests ADHD occurs in about 5% of children and 2.5% of adults. So out of 100 child, you might find 5 having ADHD, and out of 100 adults, you might find 2.5. So 2 to 3 persons might suffer from it. Attention deficit hyperactivity disorder is a mental disorder that most often occurs in children. It is mainly in children. But right now, there is a recent diagnosis which we call the adult ADHD, not only ADHD. Average age of ADHD is around 7 years old. Age when symptoms appear may be at 3 to 6 years old. So the first appearance of symptoms start at 3 years old. So we diagnose ADHD in children early as 3 years old. Okay. Sometimes we do not depend on the patient's in the parents' opinion when they come for our clinic. Our child is moving a lot or is not having poor attention. We only depend on the school or the KJ or pre-KJ report, which comes from the school counselor or the pre-KJ counselor or social workers saying this child has issues as regard the movement, as regard the concentration, as regard the attention. It is more frequent in males than females. So 2 males in compared to 1 female in children and 1.6 in male, 2.1 in female. So it is more common in males. 50% of children with ADHD might grow into adult ADHD later on. It means 50% of the children might cure completely when they grow up, but 50% of them, of children with ADHD, might grow into adult ADHD. Adult ADHD, sometimes it is around 2.5 to 4 of the whole population. Hyperactivity and impulsivity is more common in males. Inattention is more common in females. Adult ADHD have 4 to 9 times prevalence of comorbid mental health as bipolar disorder or anxiety disorder. So adult doesn't become naive as ADHD. It might be mixed with other mental conditions. The risk factor for ADHD: very low birth weight, smoking during pregnancy. Smoking mom might affect their children and they might become with ADHD when they grow up. History of child abuse, neglect, multiple foster placements, neurotoxins, infection, alcohol exposure in utero. Alcoholic mom might also lead to ADHD in their children. First degree biological relative. If I have, for example, my father had history of ADHD, or my mother, or my uncle, or my aunt, I might have ADHD also when I grow up. The progressive symptoms. It begins in childhood. Hyperactivity is dominant or predominant in preschool age, most often identified in elementary school. Inattention is often predominant. So it starts in young age, they grow up, the movement becomes more, and inattention grow up also later on. The progressive symptoms, hyperactivity may improve in adolescence. When the child grow up a little bit, he started to understand or realize the rules, the consequences of event, the responsibility of being in charge to stay still, for example, in some place, or not to violate the boundaries. So hyperactivity might be decreased a little bit, but still inattention might not be decreased. It might be increased also. Substantial number of children with ADHD might remain impaired in adults. That's why we say 50% of persons with ADHD of children might grow up into adult ADHD. Negative consequences. Why it is important to discuss ADHD? Why? Because number one, it reduces the educational performance. When you have a child with ADHD, you will suffer a lot to help him to be in line with his colleagues or with the peers. Okay. Regular child, the average child might finish his school duties or school curriculum for the day in 2 hours. The one with ADHD might take 4 to 6 hours. So it is triple or quadruple the time needed for his average, for the average of his age. Number two, social rejection. Imagine if you are in one place and the child keep nagging with everyone, pushing every chair, making noise, rumbling, hitting, slapping, spitting, or even impulsivity as regarding bad words, speech, okay? So he will be rejected. For KJ, pre-KJ, for elementary school, hey, your kid is nagging, is troublemaker, better to transfer his direction in learning or in education for another specialized school or specialized group for learning, but not in the regular or in the normal schools in the community or in the country. Poor occupational performance. Of course, if he is a worker or employee in a company, he will not do well because he have inattention, he have impulsivity, he has movement, so he can't stand still. For example, if he is a security guard, for example, in one place, and he has to sit for 3 to 4 hours in front of a camera, he will not be able to sit like that. He will move around and there may be a disaster happening while he is not noticing anything. Higher probability of unemployment. If I am doing some questionnaire for my employee or for my workers, I might expel him. He will not get the chance to be steady in one job. Interpersonal conflict, always in trouble with his colleagues. because he doesn't respect the boundaries. He always crosses the boundaries. We are sitting, he might touch, he might push, he might hit, he might slap. He doesn't respect the boundaries, especially body boundaries. Okay, so people got scared from him. I don't like to sit next to Mr. X or Mrs. Y, for example. Okay, more likely to be injured. He is fidgeting in movement. He is inattentive, so he might have too many falls or too many broken bones, okay, or many slabs. It depends on his situations. Traffic accidents. He can't withstand a traffic light. He can't stay in a traffic light for 3 or 5 minutes. He might pull forward suddenly and he might hit the other crossing car from the other side. The obesity, it is related to the impulsivity. He might have impulsivity in eating. He might have eating disorders. He might eat a lot for that. He might overcome his depression from inside for being rejected by eating. Incarceration, of course, he might be stopped by the police too many times, and he might have conduct disorders. And the worst thing is the substance use disorder. Children or adults with ADHD might head towards substance abuse to overcome the sense of anxiety and the irritability and the restlessness inside their mind. Diagnosing ADHD, of course, we diagnose ADHD according to the categories. It is in attentive type or hyperactive type. Okay, it is more in children, and the duration of symptoms also. Okay, it should be at least 6 months, and we always depend on the official reports from schools or from KJ or pre-KJ or from colleges. Okay, or from police reports, for example, for too many stoppage by the police. But we take the parents' complaint into consideration. But sometimes the parents are more subjective in their complaints, not objective. Diagnosing in attentive type, patients doesn't pay close attention to details, okay, and that's why there is careless mistakes. Can't stay focused on tasks or activities, doesn't complete tasks, can't seem to organize tasks, okay, has an aversion to tasks where sustained mental effort is required. This job needs to concentrate or be focused, for example, 25 to 30 minutes. He cannot do that. He cannot do that. Mistakes, misplaces items required to engage in task activity. As I mentioned, he might bring the cup full of water, but don't put it towards the plant side to water the plants, for example. Doesn't appear to be listening. If you speak to him, his mind might be away. He is easily distracted. When sitting in the class, he looks at the birds in the window, he listens to airplane flights, for example, coming by, or a horn of the car outside, okay? It's everyday activity, forgets activity needed or required. As regarding the hyperactive or impulsive type, fidgets, taps, squirms, doesn't stay, but when he or she should remain seated. Do not move. Stay in your place for 5 minutes. No, he can't do that. Runs or climbs inappropriately, can't play quietly, always in the play. You find who is making noise. He is fidgeting, moving. He is messing with the alignment. Mr. X or Mrs. Y who has ADHD needs to be in the move, always on the move, always on the edge. Okay, talks too much, even without permission. Prematurely blares or responds to questions. He can't wait the teacher he can't raise his hand and wait for the teacher to ask him to permit him for answering, for example. Can't seem to wait his turn or his role, interrupts or intrudes. He is not respecting the boundaries or respecting the rule or respecting the consequence of procedures. Okay. Emotional dysregulation. Of course, people with ADHD have emotional dysregulation. They might cry suddenly. They might indulge in emotional impulsivity. Okay, and deficient emotional self-regulations. Okay. There are too many tests for ADHD for scales. Okay, and this is of course available on psychological evaluation, or when we have a child in our clinic, we refer him for psychologist or psychometry evaluation for him. Okay, as regarding the treatment, okay, treatment of ADHD, we should start the treatment as early as we can. In children, we might start first with psychotherapy first, okay? We do not prefer medication at early age, but in certain situations, we might start with the medication. Medication ranges from stimulant or non-stimulant. Medication has some good effects, some side effects, but of course, it is beneficiary to treat as early as we can. We always guard against indulgence in substance abuse or indulgence in illegal acts, okay? So the improvement might be 50%, might be completely cured, and the 50% might move to adult ADHD. From my opinion, this is enough for ADHD, okay?
Yeah, okay.
Good. We'll move for the second topic.
Yeah, sure.
Okay. This one finished. Okay, good. Screen. Okay. ADHD. We move towards ataxia, or which one? Or eating disorder?
Yeah, ataxia.
Ataxia, okay, good. Ataxia is the incoordination of movement. Okay. Ataxia is derived from the Greek words or meaning irregularity. The coordination of movement, our movement is always in a harmony. And thanks to God for that, it is due to our cerebellum and its connectivity. Cerebellum is in the posterior part of our skull, is in the lower part of the brain. There is the brain cerebrum. The most part of the brain is cerebellum. Cerebellum and its connectivity is related to our coordination. This cerebellum has connectivity with our vision and our inner ears, okay, from inside. So it, and also the receptors from the skin, sensory feedback from the skin. So we have what we call cerebellar ataxia. Ataxic gait.
We don't see the slide, we only see the files.
I'm sorry, screen, okay. Okay. How about like that?
It's still, it didn't change. It's on the files.
On the files only? Okay.
Yeah.
Now?
See it, yeah.
Okay, good. Okay. So it is derived from the Greek word irregularity, and I said this coordination depends on the cerebellum and its connectivity and its connection. Our cerebellum, that's why we have cerebellar ataxia and the limb coordination, okay? And the sensory feedback, that's why you have what we call sensory ataxia, okay? The cerebellum has connectivity with the inner ear, and there are the connectivity with the spinal cord that we call the vestibulocerebellum and the spinocerebellum. These, the input from the vestibular tubules in the brain and the spinocerebellum give us the coordination. So it collected from too many sides. That's why in some patients tell us, when I close my eyes, I fall down, because he depends mainly on the visual input, okay? And some other people, I have dizziness or unsteadiness or instability when I have inner ear, for example, infection, or I have middle ear infection, okay? I might have incoordination or dizziness due to the ear infection. The cerebellum input is corticopontine. The feedback, the input coming from the vision, the ears, the sensory. That's why patients with diabetes and sensory neuropathy or peripheral neuropathy might feel like moving or walking unsteady. He said, I am as walking on egg cracks. I can't, or on a cotton. I can't stand still. That's why they are always scared. If they close their eyes, they may fall down because they depend on the sensory input from eyes, from ears, from the skin. The ataxia has too many types. We have acquired ataxia, we have hereditary ataxia. Acquired ataxia, it comes due to infection from outside, neuropathy due to diabetes, for example. Hereditary ataxia is known either with metabolic defect or non-metabolic defect. The acquired cause is infection, posterior fossa abscess, cerebellitis, or due to vascular insult, hemorrhage or infarction or stroke or transient ischemic attacks, or due to demyelination, which are called MS, sensory peripheral neuropathy or Miller-Fisher syndrome, or malignancy. Sometimes there is malignancy in the cerebellum itself or in the other neurons. Okay, there are toxic drugs. If somebody gets lithium, get some medication, some drugs, it might lead to ataxia. And also there are paraneoplastic syndrome due to the effect of some medications, and also metabolic vitamin E deficiency, hypothyroidism. The hereditary ataxia either with metabolic disorders or non-metabolic disorders or DNA defect or sometimes unknown etiology. The ataxia might be intermittent, comes in periods of time and disappearing, and it might be progressive. Progressive, it means continuing on the longer run, and it is not terminated by itself. The intermittent one might comes on and off, like people who are having positional paroxysmal vertigo. It is due to inner ear infection or inner ear insult. It might comes in and off in bouts. Okay. Hereditary ataxia. Ataxia is a prominent feature in hereditary condition. It is either intermittent as hyperammonemia. These are too many reasons. Okay. Disorders of pyruvate or lactate, and there is progressive one. Progressive one is more dangerous. Okay. Leukodystrophy, abetalipoproteinemia, mitochondrial encephalomyopathy, Wilson disease, sialidosis. Okay, all these are different kinds of ataxia. Defect of DNA repair, ataxia telangiectasia, xeroderma pigmentosa, cocaconia syndrome. All these are different categories of ataxia. The most common one is Friedreich ataxia. Okay, and it is early onset cerebellar ataxia with non-Friedreich's. Patient has retained tendon reflex, hypogonadism, myoclonus, childhood deafness, congenital defect, optic atrophy or mental retardation, cataract and mental retardation, pigmented retinopathy, and there is one kind of late onset. The age might before 20 or after 20. The problem of ataxia, the main problem of ataxia is you cannot do simple daily acts. You can't, for example, put the buttons in its place. You can't tie your tie, for example. You can't tie your shoes lace. You can't coordinate typing a text on a computer, or you can't coordinate like typing some numbers on your phone. So ataxia is a problem of movement, and it affects the daily performance of living. The ataxia, we take the history. If it is acute, we also always suspect a vascular insult like a stroke or hemorrhage, and sometimes it is subacute. We always consider the others. The course, it might be episodic, comes in bouts or in attacks, and it might be progressive like inherited ataxia, for example. And the examination, we always do clinical examination, and we do the investigation. The investigation, we might do MRI, you might do neuroconduction study, you might do audiometry, you might do brain evoked potential for the hearing or for visual auditory evoked potential. Okay, we might do nerve conduction studies for the sensory ataxia sometimes. Okay, and if we suspect demyelination, we always do MRI and sometimes lumbar puncture. The systemic manifestation of ataxia, it goes through the skin, through the hair, through the hearing, through the visual acuity, through the multi-system affection sometimes. Okay, and also if it is due to infection, for example, or inflammation, we might have fever, we might vomiting, we might have stroke, tumors, metabolic disorders. Okay, and also we always search for thyroid. Sometimes we have hypothyroidism induced ataxia. Okay, and also immunodeficiency sometimes may be affecting vitamin deficiency. So it is multi-system. Ataxia needs a strong workup through a neurologist. So that's why we do, as I say, sometimes we do CT brain, we do MRI brain, lumbar puncture, nerve conduction, or electromyogram the patients, for the muscles, thyroid function test. We search also for lipids for dyslipidemia sometimes for them. The main treatment for ataxia is the treatment of the cause if we found, or the treatment of symptomatic treatment, like we give medications which work on the mobility of the body. It means it sometimes depends on the dopamine and adrenal act. We have too many medications for the ataxia, but the point is ataxia, it is unfortunately long-lasting condition. It might lead to the patient to become totally bed occupant. He can't move, he can't walk, he can't swallow properly. The treatment of ataxia might be long-run treatment. But if it is intermittent ataxia or on top of vascular insult or hemorrhage or infarct or tumor, it might be a curable one, but treating the cause first. Okay, this is like a shortcut for ataxia. Okay.
Yeah, thank you so much.
Go to eating disorder.
Yeah, okay.
Clear now? Shared?
Yeah.
Good. Eating disorder. Eating disorder is one half of teenagers, girls, and 1/3 of teenager boys usually use unhealthy weight control. So 50% of the girls and 30% of the boys might search for unhealthy ways to control their weight, like skipping meals, smoking, fasting, vomiting, or sometimes taking laxative. Okay, 42 of the first to third grade girls want to be thinner. Okay, and 81% of 10 years old are afraid of being fat. The average woman, for example, 5.4 inch, and its weight should be 140 pounds. The average supermodel woman is 5.1 inch, should be 117 pounds. America spends around $30 billion every year on dieting and diet-related products each year. Anorexia nervosa is the most common form of eating disorder, and it is the most lethal condition in psychiatry. The most lethal, the condition which is killing by itself is anorexia nervosa. It is characterized by excessive weight loss, self-starvation. He is hungry, but he's preventing himself from eating. Preoccupation with food and the progressing restriction against the whole categories of food. Some people might don't like, for example, milk. Some people don't like fish. This one prevent himself from all kinds of food. An anxiety about getting weight or becoming fat. Denying hunger. He is hungry or she is hungry, but no, I'm not hungry. Consistent excuse to avoid meals. It is 12 o'clock, for example, time of our lunch. Oh, I need to use a bathroom. Oh, I forgot a very important phone call. Oh, my friend is waiting outside. So too many excuses to avoid meal times. Okay, excessive and rigid exercise regimen to burn off calories. She got, for example, one cherry tomato the whole day. No, this is too much. I have to exercise. Vigorous exercise to overcome the calories. Withdrawal from usual friends. Okay, of course, because if I went with my friends, they might invite me for lunch or dinner. We might go for a restaurant. I will not be able to eat, so I better to avoid being with friends. The symptoms of anorexia nervosa: resistance to maintain body weight at or above or minimal normal weight for age and height. Always try to be underweight. He is 150 centimeter. His weight, for example, should 50 kilogram. No, she is always 35, 38, 40 or even more, less than that. Intense fear of weight gain or being fat even though underweight. She is 30 kilogram. She should be 50 or 60. No, this is too much. I am scared I may gain weight. Disturbance is the experience of body weight, shape, or self-evaluation. She always, or he always, she himself as obese. It is more common in girls, unfortunately. Loss of menstrual values in girls and women, and women, especially after puberty. Despite at the early puberty, she has regular menses, but when she indulged completely in the anorexia, menses stopped completely. What do counselors look for? If she came for my clinic, for example, the patient or his family bring him for me, I search for rapid loss of weight, a change in eating habits, withdrawal from friends or social gathering, hair loss or dry skin, extreme concern about the appearance or dieting. Age range, most cases are in women, ranging in the age of early teens, okay, or mid-20s. Recently, there have been more cases of women and men in 30s and 40s. The point is the social media, the modeling, your shape in the media, for example, in Instagram or Snap or blah, 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 forced or pushed too many adults. That's why it started to be at the age of 30 or 40s to go through anorexia nervosa, sometimes due to the shape on the social media. 40% of newly identified cases are in girls. Girls are more common, are more prone than boys. Significant increase in women about at the age of 15 to 24 years old. In population, it is 0.5 to 1% of the women at late adolescence might have anorexia nervosa. Even more are diagnosed under the subsurface, limited data or numbers about males. Males are less in number as regarding the anorexia nervosa. 10 million people have been diagnosed with having eating disorder of some type, because we have too many types of eating disorders. Anorexia nervosa is the most common form, and anorexia nervosa is the most important form because it is the killing kind of eating disorder. It is the killing type. People die in hospitals and in ICUs due to anorexia nervosa. Is this enough for anorexia nervosa? Can we go for a second subject or complete for other eating disorders like bulimia and other stuff?
It's your choice. Like it's your choice.
I think the main subject was anorexia nervosa, right?
Yeah.
So it's enough for eating disorder, okay?
Yeah. Okay.
To be able to catch the other two stuff, okay? Because
Yeah.
we are still having the premenstrual dysphoric disorder and the postpartum depressions, right?
Yeah. Right.
Okay. So we are going to premenstrual dysphoric disorder. Is it clear like that?
Yeah.
Premenstrual dysphoric disorder, premenstrual symptoms or premenstrual syndrome or premenstrual dysphoric disorder is a group of physical and mood-related and behavioral changes that occur in regular cyclic relationship. The premenstrual dysphoric disorder or premenstrual syndrome identify women with premenstrual syndrome who have more severe emotional symptoms. So we have two things. Premenstrual syndrome, it means a syndrome which happens for every single lady as regarding the menses. And we have premenstrual dysphoric disorder. This means ladies with exaggerated symptoms, more than the average for their age, okay, of the premenstrual symptoms, okay, such as anger, irritability, and depression are more prominent than patients or than girls with premenstrual syndrome. So incidence of premenstrual syndrome, about 75 to 85 of women. The severe form is around 5 to 10% of women, but premenstrual dysphoric disorder only 3 to 5% of women. So 85 of ladies have premenstrual syndrome, like little anxiety, little irritability, little weight change, little heaviness in the body, little change in the diet at menses time. So most of ladies have these symptoms. It is common symptoms, which is premenstrual symptoms. 10% might have severe symptoms, but as regards the premenstrual dysphoric disorder, which needs psychiatric and psychological treatment, only 3 to 5% of ladies. Premenstrual and premenstrual syndrome and premenstrual dysphoric disorders have common symptoms together. Breast tenderness, abdominal bloating, most common, occurs in 90%, headache, swelling of the extremities, weight gain. So these are common symptoms in this or that, in premenstrual syndrome or premenstrual dysphoric disorders. The affective symptoms also common in both depression, anxiety outburst, irritability, anger, confusion, social withdrawal, decreased concentration, sleep disturbance, appetite change, and food cravings. Premenstrual syndrome diagnostic mission regarding the effective symptoms and somatic symptoms. The symptoms relieved as premenstrual syndrome within the first 4 days of bleeding. When the bleeding starts, most of the symptoms are decreasing, so the curve will go down towards relaxation phase or towards the easygoing or steady phase without anger, without bad temper, without bad mood, without heaviness in the body. Symptoms occur always in 2 consecutive cycles. Patient suffers from identifiable dysfunction in social or economic performance. During this premenstrual syndrome, if the symptoms are severe little bit, the lady might be absent from her job, the lady may be angry at her house, the lady may have a domestic quarrel or domestic violence exposure either from her husband or from her children. Premenstrual dysphoric syndrome has diagnosed in DSM Diagnostic and Statistical Manual, the 4th and 5th edition. Symptoms interfere with the usual functioning and relationship. This is more important. I said it is all females have symptoms. These are exaggerated form of the symptoms. So interfere with the functioning. Symptoms are not an exacerbation of another disorder. For example, she is not depressed and the depression is increasing. No, it is isolated for premenstrual time. Symptoms resolve at the onset of menses. Once blood comes, it starts to relieve the stress and the anxiety. Premenstrual timing is confirmed by menstrual calendar in 2 consecutive cycles. So if a lady came only one occasion, has bad circumstances around the menses, only one time, we don't consider premenstrual dysphoric disorder. But if it came in 2 consecutive cycles, we might consider premenstrual dysphoric disorders. Premenstrual dysphoric disorder has at least 5 of 11 premenstrual symptoms. These are the symptoms mostly. At least one of the following: depressed mood, marked anxiety, marked affective lability, marked irritability, marked other possible symptoms: decreased interest in regular activity, difficulty concentrating, lethargy, fatigue, appetite change and food craving, sleep disturbance, feeling of being overwhelmed. Physical symptoms like bloating, weight gain, breast tenderness, edema, heaviness in the lower half of the body. The differential diagnosis. We should exclude other psychological disorder. We should exclude bipolar depression or depression itself. We should exclude gynecological disorder like infection or other causes of dysmenorrhea, endometriosis, pelvic inflammatory disease, endocrine disorder. Thyroid function, adrenal disorders. We also exclude GIT conditions like irritable colon or irritable bowel syndrome, inflammatory bowel disease, the drug or substance abuse or chronic fatigue states. We exclude all that. So we have a healthy lady, but always related to the menstrual cycles, has exaggerated symptoms of aggressiveness, of depression, of anxiety. It is premenstrual dysphoric disorder. The treatment, we have 2 lines. We have conservative treatment, like lifestyle changes, frequent exercise, nutritional supplement, magnesium sulfate, calcium, vitamin E, vitamin B. So this is a conservative, supportive therapy without medication. We have medication. We use antidepressant medications. Okay, too many modalities, too many kinds. It depends on the patient herself and the checkup with a psychiatrist in the clinic who will suit a proper medication for her condition depending on her status and the severity of her symptoms. Okay. Exercising, avoid too much salt intake, drinking soothing stuff like mint, anise, hibiscus, avoid caffeine containing drinks like tea, coffee, Pepsi, Coke, or other stuff might help in premenstrual dysphoric disorders as a conservative treatment. Okay, of course, the most important is the understandability of the partner for married ladies. Okay, when the partner is understanding the condition, he will try to ease and soothe the circumstances for his lady, so she might overcome the severity of the symptoms. Sometimes in a severe and intractable cases, we have surgical intervention like up to oophorectomy. The ovary, we might remove the whole ovaries for some ladies, but this is in very severe and intractable cases, and every case has its own circumstances. So this is a premenstrual dysphoric disorders or premenstrual syndrome. This is enough for it, I think. Okay?
Yeah, okay.
Good. So the last thing for us today will be postpartum depression. Am I right?
Yeah, that's right.
Postpartum depression. Good. Postpartum depression. Here it is. Good. Okay, shared?
Yeah, we can see the slide.
Good. Okay. Postpartum depression. Hippocrates in the 14th century provided the first description of depression called melancholia. This is a depression in general. He called melancholia. Believed it was caused by excess black biles in the brain. So in the past, they thought the brain is overcome by a black bile, so it becomes depressed. This is Hippocrates. Okay. Postpartum period is typically the first 6 weeks after delivery. So after delivery, in the first 6 weeks, the symptom 50 to 80% of women experience a transient baby blues. Sometimes we call it baby blues within the first 2 weeks following delivery. Okay, so we have a range, the first 2 weeks to the first 6 weeks. This is the old school. Right now we call it peripartum, not postpartum, peripartum depression. They found it might start in the 4th or 6th month of pregnancy by just very minimal depressive symptoms, which might increase and proceed up to giving birth, and it become overwhelming and increased and declare 2 weeks or after 2 or 4 weeks from giving birth. So we call it peripartum, around the berberium time, whether it starts for 6 months of pregnancy, 7th, 8th, 9th, or 1st month after pregnancy. That's why we call it peripartum duration. 0.1 to 0.2 of women experience postpartum psychosis. And when we say psychosis, it means it is not only depression, it is depression and the psychotic symptoms like schizophrenic symptoms are overwhelming or added to the depression. For the first 4 weeks following delivery, postpartum depression can occur anytime during the first 12 months after delivery. That's why we call it peripartum. May it start from 6th, 7th, 8th month, and might be continued up to 1 year after delivery. The women are at increased risk of mood disorder during periods of hormonal fluctuation. Why does this happen? The premenstrual, the postpartum, the premenopausal. These are 3 areas for a lady which might have a severe hormonal change. So imagine a lady full of hormones due to pregnancy. After pregnancy, all these levels of hormones went down. It is the adjustability of a lady toward this rush up and rush down of the hormones. That's why she has a postpartum depression. The incidence of depression among the women peaks between 18 to 44 years of age. Postpartum depression is common. 6.8 to 16.5 of women experiencing postpartum depression. It is known postpartum major depressive disorders. Potential impacts on why it is important, because it, number one, has impact on a baby. Number one, delayed cognitive and psychological development in the baby, further and focalized loss, delayed motor skills, increased healthcare resource use, marriage and partnership and double risk dissolution. A lady with postpartum depression is losing the capability of taking care of her baby. So she can't nurse him, she can't breastfeed him, she can't change his clothes, she can't wash him, for example, she can't dress him properly. Some ladies with postpartum psychosis might think and they might commit a homicide for their baby. Some ladies might throw her baby from the windows or might kill her baby. It depends on the severity of the condition. The lady might feel hopelessness, helplessness, persistent sadness, irritability, low self-esteem, anger and resentment towards the baby, or thoughts of harm to the baby might harm her baby. Loss of pleasure in activities, mood changes, inability to adjust to role of motherhood, inability to concentrate, sleep and appetite disturbance. And sometimes she has like a severe anger towards her husband. Why? Because she think, I am in this stage because of you, because you are the reason for my pregnancy. She might start to hate her husband, and she might ask for divorce for that. And she might hate the baby himself, and so hating the baby, hating the husband, and asking for divorce and leaving everything and going away. Symptoms range from mild dysphoria to suicidal ideation. She might think of killing herself and killing her baby, up to psychotic depression. Postpartum symptoms don't last for just a few days. It might take up to 6 months in one half of the ladies, and 1/3 might continue up to 12 months. Some people might grow into major depressive disorder later on if not properly treated. It had less than, okay, some ladies, it is more in ladies who are married at young age, okay, and also more in unplanned pregnancies, if there is unplanned pregnancy. Okay. So also common in ladies with family history of mood disorders, okay, or patient herself has a labile mood at the beginning, or has history of anxiety and depression, or if she has a previous postpartum depression or baby blues, okay, and all this as like a risk factor for postpartum depression. Okay, how to avoid this? Number one, we should screen all the postpartum ladies, okay, during the week visits, for example. We screen for them. We have a simple questionnaire. This questionnaire is provided for each lady during her women infant care, for example, visits or visits in outpatient clinic of OB/GYN doctors, not in psychiatric clinics, especially after pregnancy, after giving birth. The questionnaire is given for the ladies. Sometimes we give it for the ladies before giving birth. Do you have a history of that or this or no? It depends on the condition and it depends on the facilities available for the OB/GYN doctor, whether in a good center or a major qualified center for that. Okay. There are several tools available, as I said. Edinburgh postnatal depression scales, patient health questionnaire number 9. Okay, the male depression anxiety checklist, the Center of Epidemiological Studies depression scale. Also, all these are different questionnaires are provided for ladies either pre-partum or even postpartum. Okay, to overcome, to check or to be ready if she has a history of blues before. Okay, this is like example. Ask 3 simple questions. 3 simple questions. Have you felt overwhelmed in the last 7 days? Do you have thoughts of harming yourself or your child? Are you having difficulty adjusting to your new role as a mother? If the answer is to any of the above question, then provide referrals for public health nurses or health provider department, or even for psychiatric clinic for more screening and for more management. the point is, some ladies might think it is normal to have depression and difficulty after birth. That's why do not depend on your friends or your colleagues. No, it is not normal to have postpartum depression. It is not normal to have difficulty dealing with your baby after birth. The normality is you should be happy. You should be happy. You should be able to manage and do well with your baby and your husband after birth. But some is okay. All ladies have that. That's why we have severe forms of the postpartum depression coming for our colleagues, because the anticipation of most ladies have that. So some ladies might become shy. Why I have to complain? My mother, my sister, my aunt has these symptoms before. Am I less than them? No, it is not the right thing. Once you have symptoms, you should come to ask for help, or ask for help anywhere you are. Okay. Also, we have like home or outpatient visits. We have 10 questions. So it depends on the condition itself. So we are interpreting the questions and giving a score for a lady. For a lady, if it is 9 or less, low depression. If 10 or 12, modest concern. If 13 to 18, moderate concern. If 19 and above, so it means have depression and worry about suicide risk also. Okay. So that this is like example of the questionnaire we are providing for our ladies. Okay, and to have the scoring. Okay, if you found the postpartum depression, ladies, why ladies are hesitant to come for our clinic for postpartum depression? Because sometimes they think there is no treatment, or there is no cure, or oh my God, I gave birth and I'm breastfeeding my baby. I can't get medication because I'm breastfeeding my baby. Your medication is harming for my baby. No, all these are wrong. We have proper medications which fits for breastfeeding right now, so we can give medication, and we have also counseling or psychotherapy. Okay, and the medications are safe whether for the lady after giving birth or for the baby himself. So right now the modalities are available, but the misunderstanding of people around about our medications, it will not fit for the baby or not fit for breastfeeding, and it is haram to prevent breastfeeding. No, we are not preventing breastfeeding. Our medication is suitable for breastfeeding, so it is good and accepted and has no side effect or no harming effect for the baby or for the mother after delivery. Okay, so postpartum depression is common. Okay, may have long-term consequences for the mother, infant, and the family, and it is easily missed. Should be screened for and can be treated successfully. Okay, the kind of treatment, of course, we have too many modalities. As I said, we have psychotherapy, we have pharmacotherapy. Mostly we give antidepressants. Sometimes we give antipsychotic if it reaches to postpartum psychosis. I finished for today. If there are any questions, I am ready. Okay.
Yeah. Okay. So I have a question. بس هو بالعربي فأعتقد إنه يعني لو ينفع حضرتك
good. I answer in
تجاوبي
Arabic. It's okay, no problem at all.
Yeah, okay. بنتي بطيئة في الفهم والأداء، ولكنها مش ناطي، يعني هي هادية، ولكن مستواها ليس مثل زملائها. هل عندها ADHD وكيف أميزه في أبنائي؟
هو زي ما قلنا في جزئين في ال ADHD، في الجزء الحركي وجزء التركيزي. اما تبقى بنتي بطيئة في الأداء وبتتأخر عن أقرانها وما بتستوعبش مثلا بسهولة، ماشي، دي ممكن تكون الاناتنتيف تايب، اللي هو جزء الانتباه، يبقى ما عندهاش حركة لكن عندها ضعف التركيز والانتباه. يبقى قلنا في اسمها فرط الحركة وتشتت الانتباه. قد يكون انتباهها ضعيف شوية. دي لو احنا شاكين في كده بنشوف اقرب سيكولوجيست عندنا في المنطقه بتاعتنا وبنحاول نعمل لها المقاييس. المقاييس بتوضح بالظبط ايه المطلوب. المقاييس ما لم يكن البنت تحت ضغط نفسي. ساعات بتبقى البنت ضعيفه التركيز وضعيفه الانتباه من الرعب اللي عليها. والله انا مامتها بقعد اذاكر لها والكف موجود 1 + 1 = كام؟ = 3. يا وحشه = 2. يبقى البنت قاعده يا عيني وايه وعينيها في وسط راسها وخايفه من الضربه اللي هتجيلها. تبقى البنت يا ترى البنت هتركز في الكتاب ولا هتركز في الضربه اللي هتجيلها؟ فاحنا بنخاف من الحته دي. فدائما كده الاول نوفر البيئه الامنه اللي الطفل بيذاكر فيها بصوره طبيعيه. لو ما فيش ضغط على الطفل ولقينا ان التركيز والانتباه ضعيف يبقى ساعتها هنروح نعمل المقاييس عشان ما نتوهش.
أيوة تمام.
ماشي اوكي.
أيوة. برضو بالعربي، إذا أحد أخذ دواء ال ADHD ولكن وقفه بعد 3 شهور لأنه كان بيتعبه وبينام كتير وفي عدة يعني حاجات يعني خلته يوقف، هل يمكن إن هو يرجع للدواء بعد 2 من توقيفه؟ وإيه الدواء المناسب يعني اللي يكون فيه آثار جانبية أقل؟
الأدوية في أنواع مختلفة من الأدوية زي ما اتفقنا. في أدوية تهدي الحركة بس لكن مالهاش دعوة بالتركيز خالص. وفي أدوية بتساعد على التركيز ومالهاش دعوة بالحركة. وفي أدوية بتساعد على الانتباه ومالهاش دعوة بالحركة. الأدوية في منها حاجات منشطة وحاجات مش منشطة بيسموها ستيمولانت ونون ستيمولانت. بقولها كلمة كده بالتشبيه البلدي. أنا لو بشرب كوباية الشاي دي، في واحد بيعوز مع كوباية الشاي معلقتين سكر، واحد بيعوز معلقة سكر، واحد بيعوز من غير ولا معلقة. الدواء اللي بيفصل له الدكتور، الشطاره انك انت لما تروح للدكتور تاخد دواء ما تروحش وتسكت بقى، انت بتتابع الدواء مع ابنك او مع بنتك، والله ظهرت اعراض، في اعراض متحمله ومقبوله والدكتور يقول لك اوكي دي اعراض طبيعيه موجوده من الدواء نفسه ما تخافش ابدا وواصل عليها وبتعدي بعد فتره، وفي اعراض بتبقى مزعجه دي اللي تخلي الدكتور يسحب الدواء ويضيف لك دواء ثاني. طبعا ادويه الاي دي اتش دي مش ادويه مثلا ادمانيه او على لونج جراند، ممكن تاخدها فترات طويله وممكن توقفها براحتك، ممكن توقفها شويه ممكن ترجع تاني شويه حسب احتياج الطفل او الطفله، بس اللي هيتحكم فيها الدكتور اللي بيعالجك في الاول. فانت احسن حاجه بترجع للدكتور، والله يا دكتور الدواء كذا، ايه الوضع بتاعي؟ طب ايه الاعراض اللي عندك؟ لا دي اعراض متعارف عليها وموجوده في الكتاب وطبيعيه وما تخافش منها، خلاص روح وتحمل ما فيش مشكله ابدا ما دام في اطار التحمل. لكن اعراض موجوده في الكتاب بس اكتر من تحملي انا، يبقى خلاص هوقف واغير الدواء تاني لنوع تاني مختلف جدا ما فيش مشكله ابدا. وحاليا في لا يقل عن 7 أو 8 ادويه مختلفين للاي دي اتش دي حسب احتياج الطفل وحسب اللي بيشوفه الدكتور بعينيه، فما فيش مشكله ابدا.
أيوة ممتاز، شكرا لك. وأنا أخذت دواء اكتئاب ولكن عندما لما صحيت لم أقدر أن أتكلم وأوقفته بعد هذا اليوم. هل المفروض أن أخذ نوع آخر؟ يعني هل دوت يعني شيء طبيعي إن هو يحصل؟
هي حسب حاجتين. الجرعه ساعات احنا بندي الدواء ساعات تبقى الجرعه تقيله شويه عليك، احنا ساعات بنحسب الجرعه حسب الوزن بتاع المريض نفسه، فساعات تبقى الجرعه تقيله، فساعتها نقول لك والله ما تخافش يمكن اول يومين او 3 تحس انك دايخ شويه مرهق شويه خاملان شويتين، ده طبيعي من الدواء. وساعات بنلاقي نفسنا لو الدواء ضغطه تقيل عليك ومرهقك جامد ساعتها بنقول لك مثلا ابدا بنص حبايه او بربع حبايه حسب الاحتياج بتاعك. وبرضه الادويه حسب نوعيه الاكتئاب، في اكتئاب بيجي للمريض بنوع من الكسل والوهن والخمول، يبقى ساعتها انا كدكتور شاطر بديله الادويه المنشطه اللي تديله الطاقه والحركه والايجابيه. وفي واحد تاني بيقول الاكتئاب مع الحركه والقلق والتوتر والانزعاج فيقوم اديله الادويه ايه اللي تهدي الكلام ده. فبرضه هي فكره ميزانه وفكره التفصيل، احنا بنفصل التوب للمريض. فانت لو الدواء خدته واول يوم كان تعبك جامد بنستحمل في الغالب معانا مساحه من 4 ايام لغايه 10 ايام احيانا من بعض الاثار السلبيه في الاول اللي هي بنسميها الاثار التجهيزيه، جسمك كانه بيجهز نفسه عشان يشتغل صح على الدواء، فساعات بنستحملها في الاول طالما ان مش حاجه مزعجه، يعني مش حاجه مثلا ايه ما حصليش اغماء وفقدت الوعي مثلا يعني، لا فساعتها ممكن نستحملها. ممكن تقوم الصبح كده بيبقى فكره ايه كان انا صحيت لكن لسه مخي نايم، كان الدواء منيم مخي من جوه مهديه شويتين، ممكن نستحمل كده اسبوع ولا 10 ايام ونشوف. لكن لو استمرت اكتر من كده وازعجتني في الاداء بتاعي برجع للدكتور يغير لي الدواء مفيش مشكله ابدا، يا اما يقلل الجرعه يا اما يغير الدواء.
أيوة ممتاز، شكرا لك. وفي أعتقد آخر سؤال إن يعني هل في أي حاجات يعني نقدر نعملها غير الأدوية إن إحنا يعني نبعد اللي هو بعد الاكتئاب ما بعد الولادة؟
في حاجات غير الادويه زي ما اتفقنا. اول حاجه الهيلث اديوكيشن، السايكو اديوكيشن، ان قبل الولاده بتكون الانثى اللي عندها تاريخ لكده او عندها احتمال كده بتكون متواصله مع السايكو اديوكيشن نيرس او الهيلثي نيرس اللي موجوده في المنطقه، فتقوم بتدي لها هي وجوزها من 3 ل 4 جلسات سلوكيه تعريفيه بالسيكونس اوف ايفنتس. يعني انت لو داخله مكان كده وفي الضلمه، وعارفه مثلا ان انت بتتك على زرار الكهرباء ان ايدك هتتلسع لسعه خفيفه، ما تخافيش ابدا، مش هتاذيكي في حاجه. يبقى انت لو اتكت على زرار واتلسعت مش هتخافي. لكن لو داخله كده وما عندكيش اي خلفيه وبيتك وحاجه اتلسعت لسعه خفيفه، هتتخض وتنزعجي على نفسك. فيقوم اما تيجي الهيلث اديوكيشن نيرس بتشرح للمريضه وزوجها، اهم شيء يكون جوزها موجود في القصه اللي عايش معاها، عشان التفهم بتاع ده اللي بعد. فيبقى اول حاجه الاديوكيشن بتاعنا، الانتسيبيشن بتاع الحاجه نفسها، الهيلب او السبورت بتاع الفاميلي والكير جيفرز اللي موجودين، سواء الزوج او الحما او الحمايه الموجوده او اخوات، يعني البيئه المحيطه حواليها، التغذيه الجيده. احنا ساعات بنقول السلطه الخضراء والفواكه والعصائر الطبيعيه، السوائل بكثره، الرياضه 45 دقيقه في اليوم، بيحسن المزاج النفسي لاي مكتئب على مستوى العالم بنسبه 30%. يبقى ده برضه هيحسن المزاج النفسي بالنسبه لمين؟ للبوست بارتم ديبريشن. لو احنا عاملين حسابنا بالكلام ده كله مع الاندرستاندنج. تخيلي كده لو واحده والده دلوقتي وبدات تعكن شويه مزاجها شويه، هتخش بوست بارتم، وجوزها اول ما دخل لها معكنه جاروخر هو كمان لو يبوظه، وانت وشك يقرف، وانت مش عارف ايه، وانت عرفتينا بمزاجك، هو انت مش فرحانه ليه، هو انت ما كنتش عاوزه الولد ده، هو انت ما بتحمديش ربنا ليه، وقعد يشككها حتى في الدين بتاعها وحمدها ربنا على الولد اللي جاء او البنت اللي جت. تخيلي يبقى شكلها ايه بالله عليكي. لكن لو هو متفهم وعارف الله دي بدات تدخل في السكه، راح ازيك، اخبارك، شكلك النهارده احسن، ما شاء الله، بتيجي نلعب الاموره شويه، المولوده مثلا او المولود، طب بصي سيبي انا اللي هغير له النهارده، بقول لك ايه، ما تخشي انت تنامي النهارده، اليوم النهارده لا نامي انت وارتاحي وانا اللي هسهر معاه شويه، معلش هصحيكي بس لو عاوز مثلا ايه يرضع بالليل ولا حاجه. فاهماني؟ يبقى التفهم بتاعه، لقوا ان تفهم الزوج ومد ايده بالمساعده الصح بيعدي 50% من الاعراض بالنسبه للبوست بارتم ديبريشن. تخيلوا.
ان شاء الله.
وغيرها بقى، لو مامتها، لو اختها، لو حماتها، مش مالك يا اختي انت بتعملي كده ليه؟ هو ما حدش ولد الا غيرك؟ الا انت؟ خبر؟ لا يا حبيبتي عادي، ما تخافيش، ده اعراض طبيعيه بتحصل، حصلت لينا، ممكن تحصل ليكي، بس ما تخافيش، لكن لو منزعجه ممكن نروح للدكتور. يبقى التفهم بتاعهم بساعتها. وساعات لما بنجي لنا المريضه في الاول بيدي لها فرصه، مش بالسلام عليكم خدي الدواء، ساعات برضه بندي لها فرصه باللي بنقوله ده، بندي لها فرصه جلسه او اتنين في الاول. لكن لو لقينا الوضع مزعج وداخل في عمق الاكتئاب بشده، وبدا الاهمال لنفسها وللطفل ولا افكار انتحاريه، لا بنبدا الدواء بسرعه.
أيوة ممتاز، شكرا لك دكتور. أعتقد ده هو آخر أسئلة. إن شاء الله لو في أي أسئلة تانية يعني نبعتها لحضرتك.
يا أهلا وسهلا، تحت أمركم طبعا، ويا أهلا وسهلا بكم.
إن شاء الله. يعني بجد بنتشكرك على كل الحلقات الغنية بالمعلومات والمفيدة والقيمة. يعني إن شاء الله يعني ربنا يجزيك الخير. Thank you so much, Dr. Abdelwahed Abu Jazia, for all of these valuable information and for the series of psychiatric informations and ways to prevent the diseases and disorders and the treatments. We gained a lot from these sessions. Jazakallah khairan, and we hope to work with you in the future. Thank you so much.
Thank you very much. It was my pleasure to meet you today, and I am always ready to help, inshallah, and support. And thanks for all people working in SMIC for that. And may Allah subhanahu wa ta'ala give you the best deeds and the best rewards, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.
صبغتك اللهم لتبقى وعليها